afternoon to all. And at the very outset, I would like to thank Dr. Sharda Jain ma'am and Dr. Poonam Goyal, Dr. Vandana for this opportunity to present this topic on tips and tricks for ovum pickup and embryo transfer. So last time this was to happen, but somehow we were short of time and we could not take it last time. So all stalwarts are logged in with us as chairs. Dr. Shada Jain ma'am herself, she's there. So, all of us are already doing this, and I don't think anything new for seniors is going to be there. But yeah, I'm going to discuss a little bit about difficult embryo transfer and my experiences, and we can later on discuss about the experiences from various different people, different faculty who is logged in, and few people who may not be doing IVF and embryo transfer and are only restricting themselves to IUI. They may, it may be something new for them, and they can also have an idea about how exactly it is to be done. So by the time we reach this step of oocyte retrieval, we have already undergone through these all steps, that is counseling the couple, clinical examinations, investigations, then optimization, which may be in form of a surgery also. Sometimes suppose there is a big fibroid and it needs a surgery. So all this we have already done. Stimulation, I'm not going to discuss, triggers, hormones, and finances, financial counseling also. It is very, very important, and especially after this new ART law, it is very important to sit with patients. Your counselor is to have a session with the patient. Financial counselor has to have a good session with patient, and we should, in writing, take signatures that all this is explained to the patient. So this has become very important, and even the ART inspectors who came, they said that the correct finances which you explained has to be, a copy of it has to be in the file of the patient. So that was new to me, because we are not adding this in the IPD files of our patient. So coming back to the procedure, oocyte retrieval, all of us know that this is first active step towards the creation of life, and it requires a fine coordination between eyes, hands, and foot. And if we master transvaginal ultrasound, we will automatically become better at it sooner. So those who don't know transvaginal ultrasound, it is a little bit difficult for them. But once you know your TVS scans well, and you can easily focus ovaries, whatever the position of ovaries may be, how difficult TVS may be, then you will become a better person doing a egg pickup also. So let's go to the history. So Ian Donald introduced ultrasound in 1958, and then TVS was introduced. And later on in 1981, it was Lenz who introduced trans-abdominal trans-vesical OPU. And then Gleiser in 1983, so not very far back, 1983, Gleiser introduced transvaginal scan guided OPU, which all of us practice. And then Bartel et al. Introduced trans-abdominal OPU with a TVS probe in 2011. So just 12 years back, trans-abdominal OPU with TVS probe was introduced. So how to decide what is the best way, and also all this literature, has proved that why all of us are doing transvaginal, because it gives minimal injury to the ovaries and subsequent corpus luteum. We get maximum number of oocytes by this route. It is a speedy procedure, and it is easy to learn. So prerequisites before we take up our patients for egg pickup, a good PAC. So we should never underestimate the egg pickup procedure, as we should not be labeling it as a minor procedure, because patient has to be medically fit. And all of us who are practicing IVF since years, all of us have witnessed problems on table once or twice at least in years, that if we have not worked up our patients well, patient is asthmatic, or we have not taken some special precautions for diabetics and all, so problems can happen. So a pre-anesthetic checkup we always do beforehand for all my egg pickup patients, and we should do. Then consents, they become so important. There are n number of consents which have been added, new ART forms and all. So all this we have to keep in mind. It's a time bound procedure, and between 34 to 35 hours after trigger I'm doing it. Literature says antagonist cycles, you can do it 34 hours later and 35 hours later after agonist. Most of people have shifted to 35 hours now. Now, as far as the instrumentation is concerned, a good ultrasound machine with a good transvaginal probe, vacuum pump, we are using Cook aspiration pump, then you should be familiar with single lumen and double lumen needles. And this is how a trolley, prepared trolley for egg pickup procedure looks like. So all this, everybody is aware of those who are not doing IVF. This is guide which is attached over the transvaginal probe, and the OPU needle, egg pickup needle, that passes through this guide. You should have a good lab with laminar flow, incubators, and all those things. Here, I'll take a pause to say that, this is a must thing which you should have, a test tube warmer, because while doing egg pickup procedure, the test tube temperature has to be maintained. We also have metallic blocks, which we heat on the metallic plate before we start egg pickups, and the temperature of tubes has to be maintained all the time while the aspiration is being done, while it is being shifted to the IVF lab through that transfer window and all. So that's the very, very basics. So a good hand wash, as any other procedure, we don't use scented soap specifically in IVF lab. And you can wash your hands either only with water and thoroughly wash, or use non-scented soap. So we are still using hammam soap because it is, it is known to be least scented soap till now. Then clean your probe with alcohol, the transvaginal probe, followed by a thorough washing with the saline, and then cover it with this plastic probe, which you can see, which is put in the distal part of the probe, and then putting a cover. This is a condom cover, which is not having any spermicidal cream or anything, and is specifically those brands you have to use which are specifically meant for this. And this is how an open guide looks like, which is to be fixed over the transvaginal probe. And after every procedure, this guide, the patency of this guide should be checked. So if I'm done with the procedure, I'll wash this guide with help of saline. And if I'm starting the procedure, then preferably I'll check the patency with a media. Then that time I will not be using the saline. So this is how the guide is fixed over the transvaginal probe, and then screw is tightened, and this is a ready probe. This is how it looks like. So cleaning with saline, it's important because all of us are using saline for cleaning vagina, and none of us is using antiseptics. But in few cases where severe endometriosis and all, those patients specifically who are in pain all the time, I do use betadine followed by a thorough cleaning with saline. So till when the returns are clear. So this is kind of a jet which we put in vagina with the help of a saline bottle, and till when the returns are clear, there is no mucus, nothing. So till then the vagina is to be thoroughly cleaned. And as I said, this is how the trolley looks like. So I'll quickly take you through this video, and I'll skip some part of it because for all of us, we do routinely all these procedure, cleaning with vagina, cleaning with saline, and then draping the patient, and then like starting the procedure. So this tube is the tube is connected to the suction pump on one side, and on the other side it is connected to the ovum pickup needle. So it creates kind of a system. So first of all, we have to flush the entire system with the help of this media. Why? Because it will make the entire system non-toxic, and then this needle is going to go through this guide. So I'm showing a little closer picture so that those who haven't done, they understand it well. So you can see that now the needle, this is the needle tip which we can see, and you have to aspirate till the last drop, otherwise you will miss on the eggs. So I'll show you a video which is, so like this is a polycystic ovary case. So these kind of cases are little tricky cases, and here we can see both the ovaries are sort of kissing ovaries. So for the beginners especially, it is very important that this mark which we can see on the ultrasound screen, the needle has to be going through across this mark inside the follicle. How to make out that you are in correct plane? The follicle looks jet black. So if the follicle looks jet black, that means you are in the right plane. All the time your needle has to be in the center of follicle, and keep on aspirating till the last drop. Few people, they prefer curating after aspirating, few don't. So because literature doesn't support about curating, so you can decide on that. I curate a little bit after the follicle is aspirated. So all the follicles, one by one, preferably going from proximal to distal and from lateral to medial. So there is a reason behind it. Why lateral to medial? Because see, it's an ovarian fossa like this. The vessels are there on both the sides. So once the ovary becomes lighter, it tends to move more. And just look at this vessel which is there. This one is a vessel. So in longitudinal, longitudinally, when you see a vessel and you move your probe, sometimes it looks like a follicle only. So you have to be very, very careful that you should not be pricking onto the vessels. And lateral to medial, why we want to go lateral to medial is because the ovaries, they become lighter, tend to move more, and there is more chance of injury. But all of us know that, by experience, now we've done so many cases. So it's not a must that you have to go lateral to medial, but yes, proximal to distal, we should always maintain. And whatever follicle you feel is coming in the way and is easy to access, you can keep on aspirating that. But for the beginners, it is important they should follow certain principles. This metallic block, which I said, it has to be all the time on the heating plate. So I have just kept it here just to, show it to you that how it looks like, and they are preheated all the time. So I want to share this very short clip where it is a case of an ovary which is lying behind the uterus. So you can see the uterus is here. We can see the musculature of uterus, and the ovary is lying behind the uterus. So somebody, what we are doing in this case is a person is trying to manipulate. So even you can train your ward boys for this. So a person is trying to manipulate the ovary from the abdomen and trying to bring it up. So see how beautifully it has come up. So I'll again show you. So just see, this is how the ovary is lying behind the uterus, and just by little manipulation from the abdomen, it has beautifully come up. And now we can start aspirating. Important thing is the person who is maintaining the position of this ovary should not move the hands and should keep it static while the needle is inside. So I have standing instructions for my assistant that your hand should not be moving while my needle is in. And now, as you can see, it has become almost like an easy pickup, but some cervical tissue sometimes we have to go through. So this case I put just to show you how abdominal manipulation helps you. Once in a while, if you give traction on the cervix, that also changes the position of ovary a little bit, especially for ovaries which are lying behind the uterus. So you can try even that. I usually do it with little bit of abdominal manipulation, and the traction or the pressure should not be too hard. Just remember, otherwise you can injure the ovary also, because they are very, very fragile at this point of time. So a very gentle, controlled pressure, I will say, to make the ovary static, maybe with the help of two hands or one hand, while the main person who is doing the procedure through the vagina. So again, for those who are looking at IVF procedures for the first time, this is how, these tubes where we are collecting the aspirate from the follicles is being transferred through the transfer window to the IVF lab, and my embryologist is simultaneously telling me that whether they are getting the eggs or not. And this is how they look like. The eggs look like. This is called cumulus, oocyte cumulus complex. And after 1.5 to 2 hours, these eggs are denuded, and this is how they look like. When you're going for ICSI, you denude the oocytes, and this is how they appear. And we should always be disposing of the needle in a very, very correct manner in a container which is meant for sharp objects. So let's quickly look at the SOPs. What are the important points which we have to keep in mind while doing these procedures? So a good communication between surgeon, anesthetist, embryologist is a must. So like if I posted a case, my embryologist will know whether this particular patient has a male factor, female factor, what time the trigger was given, does male factor exist, and do they need to add any special techniques, maybe oocyte activation if there is a history of previous failure of fertilization, maybe IMSI, maybe PIXI in some cases. So a very good communication with embryologist is very important, as well as with anesthetist. So routinely I don't call anesthetist, but if there is any medical problem to the patient, I especially we make it a point that we call up anesthetist a day before and tell them that this particular patient we are anticipating a particular problem. So, and we know that OPU is a time bound procedure, just like Mahurat cesareans people are getting. So yesterday La Femme had 9, 10 elective cesareans because people wanted that Mahurat cesarean because of Ganesh Chaturthi. So our OPU procedures are always Mahurat procedure. We cannot delay them. Like we have to be on time. So reach at least 15 minutes prior, check ultrasound, suction machine, everything. Confirm trigger time before induction. This is must. Should be in routine. My nurse or me, doctor, both of us, we check whether patient has taken the trigger at the right time or not, or by mistake they've taken a day later or earlier or whatever. And then all the consents have to be in place. Again, it is very, very important before I start the procedure that bladder has to be empty. So just before I take my patient on the table, I make sure I tell the patient, please go and pass urine. I don't want any unnecessary catheterization. But even after this, sometimes when there are big ovaries, multiple follicles, by the time you're finishing one ovary, the other, and you come to other ovary, the bladder fills up. So if bladder fills up, then under asepsis, you have to empty the bladder. It is very important to prevent all injuries, number one. Number two, you will always see that once your bladder is empty, the ovary approachability, that becomes much, much easier. Gentle vaginal toilet, we have already talked about. Once we start doing egg pickup procedure, first of all, a good scan to look for the position of ovaries, major vessels, how the POD is looking like, is there any hydrosalpinx, is there any endometrioma, is there a fibroid, am I anticipating any difficulty? Although you must be doing all your scans yourself, I'm also doing all my scans myself, and we anticipate problems beforehand, like while we are monitoring our patients in OPD. But still, before we start, we should have an idea about this particular ovary is looking difficult. So always start with the easier ovary first. During egg pickup procedure, probe should be very steady. Otherwise, the tearing of ovary may happen. Then needle should be very gently and softly handled, and both hands have to be parallel to each other and close to each other. Once the needle is inside the follicle, my eyes have to be on the ultrasound screen, and needle tip should always be visible as a rule. There should be minimum tissue between the probe surface and ovary. So a good approximation is must, and always try to enter the follicle at 90 degrees. Aspirate from proximal to distal and lateral to medial. As I said, it is always better. Then before changing the plane, the 3-step rule, we have to practice. Withdraw the needle a little to release the ovarian tissue, and then change the planes. But at the same time, see, that day I presented the same talk and I was going through Gardner. They say that try to make minimum punctures in vagina, which I feel is probably incorrect, because suppose your follicles are lying in different plane, and if you go through the same puncture, then you will make this puncture a tear, because you are going in all the planes through that vaginal puncture. So at the cost of making a few more sharp punctures, we should try prevent any tear or hemorrhage. So the 3-step rule is, while you are going inside the follicle, the first thing is you should handle your probe firmly, focus the follicle. Follicle should look like a jet black rounded structure. Once the follicle is focused, then my needle is going to get advanced and it has to be in the center of follicle, and then I start the suction. And while I stop doing aspiration, the reverse is to happen. First of all, I'll stop the suction, then I withdraw the needle, and then I change the plane by moving the probe. So this is very, very important, which comes by practice, because beginners, they do make this thing, they do make mistakes, because we make our fellows do this, and it needs a little bit of practice to follow this 3-step pattern. So after all the follicles are aspirated, rescan. It is very important. Look, any collection is there, then any doubt of hematuria, or like when we do the ultrasound, when we see there is bladder is filling up, sometimes if there is some blood, you can see the echoes in the bladder. So be little careful, because those sharp puncture, if accidentally also you have entered, if it is going to get healed, but you should know that this has happened, then only you can take all the precautions. And sometimes once in a while, 1 or 2 inaccessible follicles, all of us have to leave. We should do that at the cost of not making any problem for the patients. So what are the difficult OPUs? Difficult OPUs, in what all cases we anticipate? When there are too many follicles, or when there are very few follicles, because the ovaries are going to be very light, very thin patient, very obese patients, then any pelvic pathology. So in all these cases, even fibrous vagina, small ovaries, endometriosis, we have to be little more careful, and we anticipate difficult OPUs. So as soon as your procedure is done, your patient is out of anesthesia, first question is how many. And now this how many, everybody, all patients have a right to know. So they should know how many eggs we got, because your quality and all, we will be able to tell them later, only after 2 hours or so after denudation, if we are doing denudation, or once my embryologist gives a final call. But what is the initial number, we tell to all patients. And at the time of discharge, we do mention how many M2, M1 and GVs are there. And later on, obviously after 3-4 days, patient needs to get a call for how many embryos they have made. So the new ART law also says that a proper discharge paper mentioning about the procedure, the number of eggs and everything should be written properly on the discharge paper, which is given to the patient on the day of egg pickup. So transabdominal OPU, I have done 1 or 2 only in last so many years. So that means most of the cases, by doing this abdominal manipulation and all, we are able to get through. Also, once in a while, if suppose by all manipulations the ovary is not coming up, little bit of cervical tissue, lower part of uterus, I'm sure everybody has done that, have to go through that particular part. It's little difficult, and you have to be giving a, these punctures have to be very, very confident punctures when you give these punctures through uterus and you reach the difficult ovaries. But literature has case reports where they have done transabdominal retrieval of oocytes using transvaginal probe. So I came across this one case report where there was a case of uniconvate uterus, and they said that one of the ovaries was normally positioned, but the other ovaries was quite high up. And in transvaginal scan, it was looking like this. This is the ovary, which is highly placed, and these vessels, they were coming in between. Whereas in the transabdominal ultrasound, the ovary looks quite approachable. This is the abdominal wall. So this is looking quite approachable. So these kind of cases are cases where we can go through transabdominal route also, but we have to anticipate this. Ideally, it should not be happening on the day of egg pickup, because a proper counseling about injury to the surrounding structure, ureter, this and that, hematoma, not getting eggs, all those things have to be explained to the patient well before time. This is very, very important. And because we do our own scans, we will easily be able to make out which ovary is going to create problem. So like I tell my patient that your one ovary is stuck behind the uterus, let's see how it behaves under anesthesia and all those things. So most of the times under anesthesia, ovaries which are looking behind the uterus, they actually, they are easily approachable with little bit of manipulation, if at all, through the abdomen. So as far as OPU procedure is concerned, we conclude that oocyte retrieval under ultrasound guidance is still a blind procedure. And as we cannot see the OCC clearly, the technique has to be perfect. Entry of needle, preferably at 90 degrees, placement of the needle tip in the center of follicle, the right suction pressure, patience till the last drop is aspirated. This is important because every egg is important. Then flushing of the follicles wherever needed. I don't flush follicles anymore because I feel it is very, very potential source of infection. And believe me that, even if there are two follicles, it is almost giving same results, although literature does support somewhere that if the number of follicle is too less, then you can flush the follicle. So usually what I do is, if I have aspirated one follicle and if I don't get one egg, then if the number is too less, I can think of aspirating, flushing the next follicle. So again, a TB sonologist, a TBS person who is good at transvaginal scan can become a good OPU surgeon, and you will never miss an oocyte in that case. But remember, it is not a cyst aspiration. It is a specialized technique, and you need to master the art. So now I'll move on to embryo transfer, because ma'am also has to take another topic. So we'll quickly, maybe in another 10 minutes, we will finish with this, and later on we can have a discussion, I think. So practical tips for embryo transfer. So embryo transfer is rate limiting step and is the final step in vitro fertilization. And all of us know that couple has a lot of anxiety. They have reached this particular day after so much of medical treatment, you can say, or it's kind of a journey for them. Or sometimes some patients are even failed at previous failed attempts, they are even more anxious. So the most important thing is counseling and meeting the patient before embryo transfer. It is very, very important. Counsel them, tell them how the embryos are looking like, what are you planning, help them taking the decision. And nowadays we don't put more than 2 embryos. So how the results are going to look like. Only in special circumstances we can put more than 2. Otherwise we should restrict to either 1 single blastocyst or maximum 2 embryos. And a meeting with counselor. This is also not only otherwise, but as per law also, it is very important and mandatory for all patients who are going in IVF procedure, whether it is egg pickup or embryo transfer, they have to have a meeting with counselor and a session with counselor. So again, I'm not going to go in details of fresh or frozen or how many days of progesterone, because we are talking only about the procedures and tips and tricks today. So this is how the trolley looks like, the prepared trolley. And only thing which I would want everybody to see is that, because everything else we all do, this is a metallic catheter. I'm sure all centers, they have this. This metallic catheter we use when it's a difficult ET and the normal soft catheter, the usual soft catheter is not able to negotiate the internal os, then this is something which is proved to be very, very good. So these are different catheters. Again, this is metallic catheter, which we always keep ready in case we have any, kind of any anticipated difficult embryo transfer. So this is a video which again I will rush through because this is demonstrating a simple. So this is the gloves which we use during embryo transfer. It is powder free and looks like this. So I'm wearing the gloves because it's difficult to demonstrate while I'm doing the embryo transfer. So I'm just trying to show it with the help of one of my embryologists. So let's presume that this is the cervix. She's making a cervix with her hand, and this is how it is. So we have cleaned the cervix again with vagina, with the saline inside, so that it is kept firm. And there is a guide here which can adjust the distance, how much this outer catheter can traverse inside the cervix. So suppose the cervical length is around 2.5 to 3 centimeter. So counting from here, I'll be keeping it at 1, 2, 2.5, somewhere around here. And my aim is that it should not cross, the outer catheter should not cross the internal os. Or suppose it's a long uterus, you want to make it 4 centimeters. So you can accordingly tell your embryologist to put a guard at 4 centimeters. So let's presume this is the cervix. So with this outer catheter, with the stellate in place, with the right hand, I'm going to go inside the cervix, and my eyes now are on the ultrasound screen to look for the position of the catheter, the tip of the catheter, which my assistant is going to show me on the ultrasound. Now, once I'm there, then I'm going to take this stillet out, or a better way is to wait till when your embryologist is coming with the loaded embryos. So this is called after loading technique. Why after loading? Because my outer catheter is already in and my embryologist is going to come with the loaded embryos. So this is how the inner catheter looks like, with which my embryologist has brought. So I'm going to take the stillet out, and now what we are going to do is going to put the inner catheter inside this. And now she is handing it over to me. I'm holding the outer catheter with the left hand, and here you can see the marks on the inner catheter. So once this mark goes and touches the outer catheter's outermost part, that means at this point of time, inner catheter and outer catheter, they'll be at the same level inside the uterus, at the level which is just below the internal os of cervix. Now what I'm going to do is I'm going to look at the screen and simultaneously going to push the inner catheter gently, and my idea is that now the catheter on screen should be around 1.5 to 2 centimeters below the fundus. So once it is like that, I'm going to stabilize this entire complex, and now my embryologist is going to push the insulin syringe so that the catheter shows that the embryos, or the drop with the embryos is out of the catheter and is placed just below the fundus now. So once we see that drop on the ultrasound screen, what I'm going to do is my embryologist is going to continuously maintain this pressure, the positive pressure, while I'm going to bring both the catheter slowly and gently out. Now, once it is out, the next step is I'm handing this over to my embryologist, and she's going to take it to the IVF lab again to check whether any embryos are retained in the catheter. So this is how it is. So once she gives me a clearance that yes, embryos are not retained in the catheter, then we are done with the procedure. So after loading or preloading, it is performer's choice. So, it hardly makes a difference as far as the results are concerned. But usually wherever we are anticipating problems, then it is always better to do after loading, because once my outer catheter, I feel is, yes, it is able to negotiate the internal os of cervix, I'll just pull it back a little so that my outer catheter tips stays below internal os, and then I ask my embryologist to load the embryos and come. But it is definitely a performer's choice, and we all have to develop our own techniques, both for OPU as well as for embryo transfer. But yes, evidence there's a lot of evidence that ultrasound guidance has to be there. It improves the results. Now, smooth muscle relaxants, whether to give or not to give. So I give piroxicam 10 milligram tablets half an hour before the procedure, and there is literature which supports atosibane infusion also before embryo transfer. So I would like to hear it from Dr. Sharma sir and Chadajan ma'am, what they are using as uterine relaxants. So anticipate difficult embryo transfer. It is again very important. So in these cases where we anticipate difficult embryo transfers, fibroids, retroverted fixed uterus, severe adenomyosis, obese patients, frozen pelvis. In obese patients, sometimes we are, rarely this happens, but rarely we are not able to see the point where we have to place the embryo. So in those cases, while we perform transvaginal scans, UCL, uterocervical length, which we take, sometimes we have to go just by measurement, isn't it? So all of us have experienced that not able to see only. So while doing the monitoring, it is very important that UCL we should always measure. So this UCL starts 1.5 to 2 centimeter below the fundus and then till the external os. So how long we have to go before placing the embryo, especially in obese patients. Then we anticipate difficult embryo transfer in cases of frozen pelvis, multiple previous procedures or cervical surgeries. Some patient will give you history of difficult embryo transfers done somewhere else. So we have to be a little cautious in those cases. And it is always better to do mock ETs in such cases. Then even all of us have experienced, hysteroscopy. If it is difficult negotiation, always dilate the cervix with the help of dilator in those cases. And these cases again may give trouble during embryo transfer. Even difficult negotiations during IUI, these patients also we may anticipate difficult embryo transfer. So how to overcome difficult embryo transfer? We should know our patient history well. All scans, we have to do ourselves. A mock ET can be planned in anticipated difficult cases. A uterine relaxant can be given. Then suspected cervical stenosis, a prior cervical dilatation. So when I say prior cervical dilatation, then how prior? It has to be done 1 to 2 months prior to actual procedure. This is what literature supports. It's not that a day before we can dilate, because it irritates the uterus, initiates the contractions and all. So literature says if you have to dilate it a month at least before. Then finding of hysteroscopy should be properly noted down, and this is the whole idea, of doing hysteroscopy, that direction of internal loss. Sometimes it is at 3 o'clock, 2 o'clock, and difficult negotiations. So we should make a note of it and use it during embryo transfer. And obviously it is to be done by the most experienced person in the unit. Now, to make the uterine axis straight, we ask the patient to make bladder half full. If it is too retroverted uterus, then making the bladder full may decrease the visibility. So then that half bladder full may even become 1/4 full. So accordingly, we have to, we should be able to see the fundus properly, the endometrial lining properly. That's the whole idea. Then using 2 SIMs in place of Cusco also, I feel, is beneficial, because, when we manipulate these 2 Cuscos, the axis correction becomes little easier. Rarely holding the cervix with Ellis. I will not put this as a first this thing, like if I'm not able to negotiate, I'll prefer using metallic catheter than holding the cervix. If metallic catheter not helping, then only I'll go to LE. So that is kind of last resort for me. And clinician needs to be calm while performing the procedure. It is very important. Even if you're not able to negotiate, it doesn't matter. You just relax and maybe, check your bladder is not over full. Make the patient pass some urine if you feel it is pressing on the internal os. And again, try. Most of the time we are able to do by one means or other, and we just change the direction of outer catheter and we are able to negotiate most of the times. Now, as I talked about uterine contractions, I just delivered a talk on atosiban in embryo transfer. So I thought I'll take 2-3 slides from there also, because I got this opportunity to read the literature on atosiban and uterine contractions. So there are beautiful studies which say that frequency of uterine contractions immediately after embryo transfer, especially after 5 minutes, it seems to significantly affect the IVF outcomes. So this chart shows that those ladies who did not have, who had lesser contractions. So this y-axis is showing contractions. So 5 minutes before embryo transfer, then 5 minutes after embryo transfer, and then 60 minutes after embryo transfer. Lesser uterine contractions, they were more likely to conceive. So that's why we should think of using some uterine relaxant, I believe. And the p-values of becoming pregnant, this p-value was also coming quite significant for these patients. So how uterine relaxant helps? They relax the uterus, reduce the contractions during and after embryo transfer, and also few of them, like atosiban, they increase the blood flow by vasodilatation. So when I was going through literature, there are some studies which do say that it doesn't help, and more studies, they favor atosiban. So probably, we can conclude that especially in difficult anticipated embryo transfer, we can think of using this, or maybe some other drug like piroxicam, at least that should be used. But atosiban can also be thought about. As far as my experience is concerned, I have used in very few patients, but I have used it. And different literature suggests different doses, like a 6.75 milligram IV bolus dose, and continuous infusion also is suggested. So I have made a slide also for describing the dose. So see, this is favoring the pregnancy rates. Atosiban seems to favor the increased pregnancy rates. So how atosiban acts is, it's an oxytocin receptor antagonist, and hence it reduces the contraction and reduces the expulsion rate for the embryos. And also it is vasopressin antagonist. So that's why it increases the blood flow. So it has a dual modality mode of action. Again, this is another study which said that repeated implantation failure patients and repeated abortion patients, they do get help with atosiban. So we can think of using etoposide in some patients. And this is how it is given: a bolus dose followed by infusion. So what does literature says about soft and firm catheter? All of us know this. Just a revision: soft catheter are preferred. Ultrasound guidance is preferred and gives better results as compared to clinical touch. If your outer catheter stays below the internal os as compared to those patients where this went above the internal os, the results are better when your outer catheter is below the internal os while you're doing the embryo transfer. As far as location, where you place the embryos, the lower and mid cavity placement helps improving the success rate as compared to those placements where it is just near the fundus, because those transfers where we have put it just near the fundus, probably our embryo catheter touched, the transfer catheter touched the fundus, and that initiates contractions. And yes, a more experienced person, it is obvious that an experienced person can give better results. Then delayed versus immediate catheter removal, it has no difference. So some of us, we prefer that keeping the catheter there for a few seconds before we finally take it out, and some of us prefer that the drop is seen there and then we just gently take it out. So it doesn't show any difference in the outcomes. Presence of blood or mucus on catheter again says significant difference is not there, but if you see cervical mucus plug, we should aspirate it with the help of this insulin syringe. We can do in a very, very non-traumatic way. Retained embryos, immediately it is recommended we can again transfer if they go retained in the catheter while the embryologist is checking, and it doesn't decrease your outcomes. Now, the time gap between loading the catheter and doing embryo transfer should not exceed 120 seconds, but 120 seconds is quite a long time. So most of the times it is not more than 15 to 20 seconds, especially in after loading. You put your outer catheter first and then the embryos are coming loaded in inner catheter, hardly takes few seconds. And now this one, Dr. Shivani was talking about this transmyometrial embryo transfer. So just 3-4 slides I have made. Transmyometrial embryo transfer, see, what I feel is I haven't done any transmyometrial embryo transfer, first of all. And when I was going through the literature, so it supports that when there is a severe cervical factor, especially post radiotherapies, then they have said that it has got some role. Cervix is absolutely fibrosed. You've done a hysteroscopy. You could not find the cervical canal. So in those cases, we can think of doing transmyometrial embryo transfer also. And the kind of catheter and needle which is used, that is made by Tobacco Group, which is available. But again, so this used to be available, I should say, because I called up few companies, Sam Group and all, and they said that they have stopped making this. And I was going through a video where they said that even in UK they are short of these catheters and they are no more available now. So I really wanted Dr. Shivani to be there because they said they created their own transmyometrial embryo transfer catheter. So maybe next time we can request her to demonstrate if they have done any. So this is how it looks like. So this needle is little more stouter and there is an obturator also. And this is the embryo loading catheter which will be cannulated through this needle. So it is absolutely done in the same way as egg pickup. The guide, kind of a guide which we use for needle, the same kind of a guide is attached on the transvaginal probe, and through that probe this needle would be going. And once we reach the endometrial cavity, the outer line, so if we have a triple line endometrium, so just imagine the outer line. So till there the needle will be going and it will be staying there, and then the obturator is removed and then the catheter is passed through it, and it goes just a millimeter beyond this needle tip, and the embryos are placed there near the fundus. So all of us who have done difficult egg pickup, I believe that sometimes we have to go through part of uterus, lower part of uterus for very, very difficult egg pickup. So we know how it feels. So similar kind of feel while we go through towards the fundus and take our needle towards that point. So literature says under sedation, but I think we should do under anesthesia. Empty bladder, endometrial stripe is seen, the needle inserted close to the outer strip at the fundus, and catheter is inserted and it protrudes 1 millimeter beyond the tip. So as far as I know, loading the catheter in this technique is little difficult and tricky because the catheter is longer than the usual catheter. So that somebody has to practice, the embryologist has to practice for that. And this is one study in Germany. So see this, they started in 1993, started using this technique, and they observed that initially when they started, the success rate were close to 10%, so very low. And then by 2017, they could master it, and it was, the results were going to 50%. So not as a first, modality in difficult embryo transfer, first of all, we should, if there is a difficult embryo transfer, hysteroscopy, mock ET, then using metallic catheter, then holding the cervix. And I think last of all, it will come in place that transmyometrial, if nothing is helping, we can plan. This is one study which says that transmyometrial embryo transfer catheter can initiate more junctional zone contraction. So they are saying that it should not be practiced that often. But again, there are some studies which say that if it is difficult ET trans cervical also, like you're holding the cervix and you're doing many manipulations, so even that initiates contractions. So we have to choose which cases are ideal cases for transmyometrial embryo transfer, and should not be a blanket statement for all anticipated difficult embryo transfers. So embryo transfer is culmination of attempting pregnancy for any couple after multiple tests, visits, injections. So it is a very, very important step for them, and we have to be very cautious and we have to give them the best. So we have to anticipate, develop our own technique. As I said, all of us have developed our own individual techniques, what we are comfortable with, what gives our best results. We should know our embryologist well. We should know who is guiding us, how good the person is in showing trans-abdominal scans. If you have a good team, then it doesn't look difficult. And we should have a routine and we should stick to it. We should make sure that there are no distractions in the IVF OT, no mobile phones and all. And always track your outcomes. It is very important to track your outcomes, as it is an essential technique for all ART practices, and it needs repeated practice, dedication, and concentration. And we can make it easy actually with minimal manipulation, and that is the key to success. That try to make it easy by knowing your patient well and anticipating the difficulties. So data suggests that improved outcome are there with reduction in difficult ETs using soft catheters, ultrasound guidance. So practice as much as possible, have a plan, be comfortable, and preparation can prevent difficult ETs. So always track your ET outcomes and be critical of yourself. Thank you so much for your kind patience, and I think I've exceeded the time a lot. So sorry for that. And we are open for discussion, and I will request Sir and Ma'am. Yeah,
we'll take comments from Dr. Brigadier Sharma and Dr. Shardajan Ma'am. Ma'am, first you, Dr. Shardajan Ma'am.
It is always after Brigadier Sharma.
Okay, sir. Yes, sir.
Thank you. I think it was an excellent lecture, and she has covered all the aspects of ART in such a short span of time, because it takes a lot of time.
Sunita, stop the presentation.
Yeah. So I think only thing what I do extra than what Madam is doing. See, once I have transferred the embryo, I just move the catheter out about a centimeter or 2 centimeter down, and then I rotate it by 360 degrees inside the uterus only, and then I gently withdraw it, so that by chance, if some embryo is attached outside because of mucus, then it, you don't get the embryos back. So that is one thing to prevent embryos coming back, which I do all my patients. And regarding this atosiban, I personally don't use it. And I did a project when I was in Primus Hospital. It did not improve the increase in the pregnancy rate. But that may be my opinion. People are using it. I know that. But I normally, I keep on talking with my patient. I think that relaxes the uterus more than anything else. I generally ask them, okay, what you have had your food and what recipe and all. I discuss, you add this thing, that thing, and by that time she knows that the embryo transfer is already over. So see, over ho gaya, khatam ho gaya, you know. So I think that also the patient's mind, some good counselor or some sister who's trained, who's friendly with the patient, can keep on talking during the embryo transfer procedure with the patient, just holding her hand, and by the time they realize this, I feel personally has worked in my settings better than a tocilizumab. The difficulties which we can see, nowadays most of cesarean, post-cesarean IVF, the catheter may roll up into the isthmosele. So one should be very, very careful. You may actually transfer the embryo into the isthmosele. So one should be very careful. That is difficult. And second difficult cases are when there are a lot of Nemothean follicles at the internal os. So in your previous ultrasounds, you know that there are Nemothean follicles at the internal os. So that is a place where you would be having a difficult entry. Now, see, the cervix, if you remember our anatomy days, if we cut the cervix, there are some arbor vitae inside. And these arbor vitae, they are like this, and they're thicker in the center and thinner on the sides. So whenever we have a difficulty in, even putting the outer catheter, so instead of going exactly in the center of your, cervix like this, you go along the lateral wall instead of going, because otherwise what happens is catheter gets stuck in the valleys of those arbor vitae. If you try to go, centrally, so go to the lateral, because lateral side, these arbor vitae are very thin, so you are able to negotiate and reach up to the internal os. So I think these are a few points I thought which I look into. I thought I'll share.
Sir, you don't use any uterine relaxing, not
No,
even
no, no. Only my
paroxysm or anything?
TLC only.
Okay.
TLC only.
Ma'am, you.
I think Dr. Arora, your presentation had been absolutely excellent, which is slightly different. I will just share it with you. We make sure about the trigger time, and we have devised a policy that once the lady has a trigger, she will definitely give a ring to one of us, so we exactly know when the trigger has taken place. Secondly is then we make sure again by getting a urine pregnancy test done in the morning, and then again we see the two lines, then we know the trigger has been taken. And then, as you said, it is time bound, and once it's the person who is used to doing a very smooth transvaginal sonography probably will not find it difficult. I think you definitely made your case. I feel that whenever you are doing a pickup, your movement has to be from the top to bottom. This is the way, and never on the sides. Once you do side movements, then again you'll find you'll tear the ovaries. And in cases of patients with PCOD where you've done this thing, I make our patients wait for 2.5 hours, and then we again get a repeat ultrasound done at that time before these patients go. I think the rest you made it very, very clear as far as this part was concerned. Coming to ET, mock ET is must. And now people like us now definitely feel that, even doing a histoscopy prior to IVF, but previously I never used to get it done, but now we make it almost a policy that we get it done, because 20 of our cases of IVF failure, we got histoscopy done in Osamu Saki's workshop, and we found every patient has some pathology. So since but that particular time, we have made a policy to do this particular thing. Unlike what Dr. Brigadier Sharma says, that you should put the cannula from the sides. It's my policy. I always see that you should be on the posterior lip of the cervix, and you rotate, you will never find it any difficulty, provided you've done a mock ET earlier. It is always the previous cycle where we do the mock ET. We have not used any analgesics or atosiban. We had used first we did it almost 25-30 cases, and simultaneously we had ones who had not taken it. We did not find any difference. Then somebody else, we met in the conference and said, nahi, 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 doctor sahab, dobara try karo. Phir hum dobara try karna shuru kiya. Again, we did not find it. So we have had 2 times, we had gone through it, and we are definitely result oriented. So we exactly know how many of in a particular group have got pregnant. So as a policy matter, now we don't do it. And what is the studies? कोई क्या कहता है यहाँ पर इसकी हो गई वो, we don't believe it. ये सब studies हैं, ये सब drug houses oriented studies हैं, and I don't have that kind of a say. Your personal experience is the best experience, and as a policy matter we always do a suction as far as with the swab. You have swabs, we take the cervical aspiration, and then we definitely flush with the media before we negotiate our catheter. So this is what it is, and luckily we have not had any problems as far as transferring is concerned. जब हमें पता चलता है तो उससे पहले हम जब mock ET करें तो अच्छी खासी तरह से dilatation करते हैं उस time, and then we see that we exactly know which way to go. We make a diagram and things like this. So this is what I can say. The story of Etosiba and another things. I think this is all. You have covered it very, very well. Excellent talk.
Thank you, ma'am. Thank you for the opportunity. Thank you, sir.
Anybody wants to make any comments, experts? Hello?
Anybody?
Hello, ma'am. Good afternoon.
Yes.
Dr.
Yes.
Meghna.
Ma'am, it was an excellent lecture, Sunita ma'am. Wonderful. You have explained all the practical points. One doubt I have, like, if you find hydrosalpinx when you're doing the ovum pickup, then do you aspirate in the same sitting? It's clear
Never,
cut. Like, it's
never,
clear,
never, never. I never aspirate hydrosalpinx.
You leave
I
it.
never do that. No. So if you feel it is a significant hydrosalpinx, then it has to be clipped. And if you feel it is, this is what I follow. And if it is away from the uterus, and if I feel it is a distal hydrosalpinx and very small, less than 1 centimeter especially, then you can leave it and go ahead with your embryo transfer.
Okay. And endometriosis, like we can aspirate in the same sitting if we find that it is
I
coming on
never
the way.
do. Rather you have to avoid entering the
Avoid. But if it
endometrioma.
comes on the way, like if it is on
You
the way,
have
then we can aspirate followed by antibiotics.
if it is coming in the way, and if it is a big endometrioma, I'll prefer leaving that follicle rather than going through the endometrioma. And if accidentally there is endometriotic fluid, then you should wash your entire system, and even the embryologist is informed that this particular aspirate is stained with the endometriotic fluid, and they quickly scan it for egg and wash it properly before separating it. So we should always avoid pricking the endometrioma, and if endometrioma is that big enough, then you better operate it first and then go for egg pickup cycles. This is what I feel.
Thank you so much.
For endometriosis, you find a patient has had surgery, she's too reluctant to undergo repeat surgery. Majority, 99% will prefer a surgery, but daringly, Brigadier Sharma and ourselves, we do it aspiration in the beginning of the cycle. One has to be very careful. Very senior people have to do it, because if the onus comes of something like a pelvic abscess, the onus comes only to the senior people and not on the junior people. So we have done it a couple of times here. Again, I would like to have Brigadier Sharma's comment on it.
Yeah, especially, madam, when the AMH is very less and the follicles are very less, so we can't operate on the endometrioma before the ovum pickup, because as such we are expected 2-3, and the lady is adamant that she wants with her own eggs only. So under that situation, you may have to pass through the endometrioma to reach the follicle. Only thing is, don't do the suction when you are passing through. So it has to be fast through the endometrioma and reach the follicle, aspirate out, and then embryologist washes them with the herpes media 2-3 times, and then preferably we do ICSI for them. We should not do normal IVF, because the fertilization failure, because the complement and all can happen. So it's better to do the ICSI for all these whatever number of eggs. Normally, if the eggs are less, the embryologist may say, okay, if I denude it and if it is all M1, so I will do the IVF for them. But in this particular group, it's better to do ICSI, denude and do ICSI rather than do IVF. And regarding the aspiration is concerned, once you have passed through the endometrioma and you have reached the follicles and you aspirated them, and on the way back, because you have to withdraw the whole needle because your egg would be in the needle only, maybe some of them. So second puncture, you may not do it to aspirate the endometrioma. And but in case the patient, sometimes the patient has undergone too many surgeries before, and you find that endometrioma is there, and you have aspirated, you have washed your needle, and whatever oocytes or to be retrieved have been retrieved. Then you may have to make a second puncture to enter the endometrioma, and before that you must clean the vagina and all. As Dr. Sunita had mentioned earlier, in some cases where you are using betadine also for cleaning the vagina and washing it with copious amount of saline, and then entering into the endometrioma and aspirate out. And under those circumstances, sometimes I do the this thing flushing of the endometrioma with gentamicin normal saline, so that it makes endometriotic fluid thin, and it comes out faster, and then also it prevents any infection to take place. But those are the rare cases where the patient can't. And I know that if she was pregnant, this big endometrioma which is going up to the umbilicus, how will I manage it otherwise? So under those circumstances, rarely, yes, I have done it, and touch wood, there has been no infection. But yes, I washed the endometrioma with gentamicin with them.
I just also wish to tell Dr. Arora that, whether it's an IUI or IVF, I always hold the cervix. And it doesn't make any difference as far as the pregnancy rates are concerned.
I also do embryo transfer. I always hold the cervix because I do the preloading only, so not the after loading. I only do the loading of the embryos myself, and then I only bring the catheter and do it. So by holding, otherwise, see, with the Cuscos, there's nothing wrong in that. But only thing is, in case you are not able to transfer with the Cuscos, then the whole catheter has to go back to the virology lab. They will take out the embryos, and then the exposure of the embryo to the external environment is much more. So for that reason, from the beginning of my career, I have been holding the cervix and doing the preloading only. Now another thing that Dr. Sunita had mentioned very nicely, that you should remain calm. Most of the time, the clinicians become panicky. Now remember, there are only two things the embryos are worried about. One is the exposure to the light, and the second is the temperature loss. So once you're like, suppose my case, I'm doing the preloading. So my catheter, the inner catheter is also inside the outer catheter, and both of them are in the cervix. So once they are in the cervix, there is no tube light in the cervix, and there is a 37-degree temperature in the cervix. So I should not be worried, too much on that. The time to push left, right, left, right. Economy of movement should be there. One must and even passing through the cervix, it should be ultrasound guided. Now with the Cuscos, what happens? You are not able to see the cervix because the inner, the blades of this thing, they are covering the cervix. While with this, when you are holding the cervix, so nothing is there between your probe and the cervix. So it's a very easy maneuver because most of the problems are only in the cervix. Once you're, at the internal loss, then there is no problem. So that is another advantage of holding the cervix and not using the Cusco. That is my personal experience and opinion, but it does not mean that everybody should follow that. It all depends upon how you have been trained and how you have been doing it. Because there have been studies where, all factors being the same and two people doing the embryo transfer, the results were different.
Yes.
So it all depends upon, your own, how you do it and how the patient is comfortable with you. There's so many factors involved. I remember recently, I just want to share one case. This lady got a hysteroscopy and she had one transverse band, thick band, which was removed by the hysteroscope by some of the doctor, and she came for IVF to us. She had only 2 oocytes. MH was very less. And she formed grade 2 embryos. So on day 3 only, we thought we will transfer those embryos because there was no point freezing them anyway. Expecting the pregnancy not to happen. with those two grade 2 embryos. And while I was doing the embryo transfer, I found that they were I had to push the catheter and all. So I didn't know what to do with that. I tried left, right, nothing happened. So then I gave the embryos back to the embryologist and did the sounding. And I found out, oh, there is a, where the histoscope had shown at almost at the same place, there was an obstruction. So because I could not freeze those embryos and I could not negotiate. So there was a, dharma sankat over there. I just gave a little push so that band broke. And then with the rolled technique, I transferred, put the outer sheath, and then he brought the embryos, and then I did the thing. And these 2 days back only, she brought the daughter and a lot of sweets also for us. So what I mean to say is, it's not only, yes, we have to be very, very gentle and all, but if the baby is going to be born, it will be born anyway. I could never imagine. I must have taken 45 minutes in negotiating that woman because she was jumping, the passage was blocked. They were grade 2 embryos. I could not postpone it also because histoscopy dobara karenge because I knew the freezing and thawing will anyway, and she can't afford the next IVF. So everything was against her, but still, she became pregnant. So there are many factors which are beyond our understanding and which do, affect, but at the same time, this is a once in a lifetime miracle. They don't happen every day. And but don't think we should not lose courage under all circumstances because we are just playing gods. We are not gods. God may, if have to, the soul has to come, it will come anyway, under all circumstances.
Thank you, sir.
Thank you very much.
Yeah.
Excellent talk, Dr. Sunita, and really practical tips were given very nicely by Dr. Sharma and ma'am. Sir, I just take an opportunity to because you have mentioned isthmocele. So, what's the treatment basically for isthmocele?
See, basically, if you have done the embryo transfer high, just a centimeter below the fundus, then you don't have to repair the isthmocele before doing your IVF. But yes, if the isthmocele is very big during your initial ultrasonography, you may think of getting it repaired. But most of the time, at that time, they don't look that big. It is only when the patient is already stimulated and the endometrium grows, and that is the time you find, oh, there's a big isthmocele. So only thing is that when you are passing your catheter, go, as madam said, go along the posterior wall. As if you're rubbing against the posterior wall rather than anterior wall. And make sure that your tip is beyond the isthmocele. Otherwise, you may transfer into the isthmocele.
Because sir, sometimes what happens, it is almost cavity is full of fluid. This is mostly on 6th, 7th day of the FET cycle, or so either sometimes we are waiting for that and we are sending the patient for isthmocele repair, or sometimes what we have done is we have aspirated the fluid also, and that has given the result. So if that big isthmocele, I think it needs a correction.
Yeah, we should know it beforehand only, the initial ultrasonography.
Yes.
Because nowadays with this post-cesarean secondary infertility, this is becoming a big problem. Because, they are suturing in single layer and all these things are creating a problem. Earlier, we never used to see so many, when we were suturing the uterus in layers, we never used to see such isthmoceles. Nowadays, because everybody wants to finish cesarean with 10 minutes, so one single layer, and I think that is the cause of isthmoceles.
Thank you very much, sir. Thank you.
So one patient comes up with a report of that post-isthmocele repair. The uterine wall thickness at the scar area is just 1 centimeter. Should she be advised for a pregnancy at all or not? A non-pregnant uterus having a repair done, and now the thickness of its scar area is 1 centimeter.
1 centimeter is okay. I think you're thinking 1 millimeter.
1 centimeter.
1 centimeter is
1 centimeter is
10
good.
mm.
1 centimeter is good.
Non-pregnant uterus.
Yeah, 1 centimeter is good.
We take 3.5 during pregnancy.
Yeah.
mm. 3.5.
mm.
What is that? 3.5 mm in the full term pregnancy.
Full-term
If
pregnancy.
she's non-pregnant, they were asking, do we go in for a pregnancy at all or not?
Yes.
Yeah,
Like
yeah.
1 centimeter.
She can go, no problem.
She can go.
Only thing is all this, as we know, post cesarean pregnancies, they're high risk. They have to be told that in case they get pain or or discharge or bleeding, they must report immediately.
Right. So no need to get a second repair done.
No, 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 no.
Okay.